Welcome back to the deep dive. If you are preparing for a major clinical final, you know that the sheer volume of information can be overwhelming.
It's a lot.
It is. You don't just need to know the facts, you need to know the priority, the absolute sequence of life-saving steps, and, that critical medication hook that will guarantee recall under pressure.
Exactly.
So this is a deep dive, custom tailored for the learner, designed to be the ultimate high-yield shortcut.
That's right. Our mission today is to move beyond simple definitions and into critical application. We've synthesized a stack of dense clinical notes,
Covering a ton of ground.
a ton.
Yeah.
Musculoskeletal, endocrine, cardiac, respiratory, neural emergencies, and we're just distilling them into clear, prioritized action plans.
For your exam, and let's be honest, for your future practice.
Absolutely. For your future practice. Knowing the why behind the first action is everything. So we're really focusing on the disorders, the nursing interventions you need to do in that critical sequence, and how to just absolutely cement the essential medication knowledge you need to ace that test.
Okay, let's unpack this. The source material is, well, it's exceptional because it frames everything through the lens of acute care priority.
It does.
We are going to slow down, provide the crucial rationale for why we do what we do first, and really connect the dots.
Good.
We're starting with the bones, the joints, and the immediate dangers following trauma.
Let's do it.
So let's begin with the mechanics of immobilization and the non-negotiable rules for managing Buck's traction. This feels foundational, but I know the consequences of getting it wrong are, well, they're high stakes.
They are.
So what are the absolute nursing priorities here?
Okay, so Buck's traction, it's a form of skin traction. Its job is to maintain alignment and, reduce muscle spasms, especially for hip or femur fractures before they can get to surgery.
Right.
The core priorities are kind of twofold. One, making sure the traction is actually working, and two, preventing neurovascular compromise.
Okay, and that second one sounds like the immediate danger.
It is, and to address it, you must, and I mean must, check neurovascular function hourly for the first 24 hours.
Hourly. Why so frequently in those initial hours?
Well, because the initial injury itself, plus the traction apparatus we just put on, can cause a ton of swelling or even pinch a nerve.
So you're looking for ischemia.
Exactly. We're looking for early signs of ischemia or nerve damage. If you miss that, it can lead to permanent damage or, worst case scenario, even amputation. So that hourly check is mandatory to catch those subtle changes.
And when we say neurovascular function, what are the specific components you're checking every hour?
We're talking about the critical PMCS components. So P is for pain, and this is often a pain that's unrelenting, way out of proportion to the injury.
Okay.
M is for movement. C is for capillary refill. And S is for sensation. Can the patient feel you touching them? Can they move their toes or fingers?
A decline in any of those four is a red flag.
A huge red flag.
Yeah.
Especially that increasing pain that isn't relieved by medication. You have to act on that immediately.
That makes perfect sense. Time is tissue. Now, let's etch those never-dos into memory. These are the rules that if you break them, the whole intervention becomes useless or even dangerous.
Yes, these are the things you just don't do. These ensure that therapeutic pull stays constant. First, never adjust the weight yourself.
Not your job.
Not your job. That's a physician's or provider's order, based on the force they need. Second, and this is a classic test question, do not let the weights touch the floor,
Why is that so critical?
because the weights have to hang freely. If they're resting on the floor, that crucial countertraction is just gone. It's negated, and the fracture site could become unstable.
So the whole thing is pointless then.
Completely. And third, and this is all about alignment, the patient have to maintain proper body positioning. This means they don't sit up or shift in a way that messes up that alignment. And you also have to prevent, say, dependent arm positioning, because that could just make swelling worse and increase the risk of compromise.
Okay. Moving on from traction to post-op joint care. Let's talk arthroscopy shoulder or knee. The immediate instructions here are very specific.
They are, and for both, whether it's a knee or a shoulder scope, the immediate post-op assessment is that same gold standard we just talked about.
The neurovascular assessment.
The neurovascular assessment, PMCS. You are constantly assessing the extremity distal to that repair site for circulation, movement, and sensation.
But the recovery instructions for a shoulder repair are a bit different, right? Especially with movement and how you position the arm.
Yeah, for a post-shoulder repair, you're recovering from some significant soft tissue work. So the key patient education points would be, 1, avoid getting the cast or dressing wet or damaged. 2, inspect that incision daily for any signs of infection, redness, warmth, drainage.
Usual suspects.
The usual suspects. 3, apply ice packs for the first 24 hours to really get that swelling under control. And 4, do isometric exercises as instructed.
Which means contracting the muscle without actually moving the joint.
Exactly. It maintains tone without risking the surgical repair. But the most crucial restriction is this. Never place the arm in a dependent position.
So hanging down.
Right. You want that arm elevated above heart level whenever possible. It helps with venous return, prevents fluid from pooling, and that reduces both swelling and pain.
Okay, and what about the post-knee scope patient? We have the neurovascular checks, but what if they're in a cast? How do we check for problems inside it?
Well, the primary assessment is still the neurovascular status of the knee and the foot. But for any patient in a cast, you are constantly worried about swelling, which can compromise circulation.
And that's where the two-finger test comes in.
That's where the two-finger test comes in. It's simple, but it's so important. If you can't comfortably slide 2 fingers between the edge of the cast and the patient's skin, you have to suspect there's too much swelling.
Which could mean circulatory impairment or even...
compartment syndrome. And that requires immediate notification and possibly bivalving the cast to relieve that pressure.
Let's talk about that. Let's talk about these acute trauma complications. What's so fascinating is how a stable patient can just deteriorate so quickly. We have to recognize the early signs of things like compartment syndrome and fat embolism.
We do. And they can be life-threatening.
So define compartment syndrome for us. Why is it such an emergency?
So compartment syndrome happens when pressure builds up inside one of the body's muscle compartments, usually the lower leg or forearm. The injury, like a fracture, causes massive swelling, but the fascia around the muscles, it's really tough. They can't expand.
So the pressure is all internal.
All internal, and that pressure squeezes the blood vessels and the nerves. If you don't relieve it, the decreased blood flow leads to tissue death, necrosis, and eventually irreversible damage to the limb. The only treatment is a fasciotomy, which is a surgical cut to relieve that pressure.
What are the early signs a nurse has to catch?
Well, people talk about the 6 Ps, but the most alarming early sign is often unrelieved pain, a pain that is just way, way out of proportion to the injury and doesn't respond to narcotics. Other signs are, obvious swelling, maybe respiratory distress if it gets really severe, sometimes a fever. The critical nursing action is to call for an immediate assessment the second that swelling starts, or if that pain intensifies.
Right.
And a key point, you must never elevate the limb above the heart or put ice on it.
Wait, that seems counterintuitive. You'd think that would help with swelling.
You would, but it can actually decrease arterial flow and make the ischemia even worse. You want to keep the limb at heart level.
Good to know. And then we have fat embolism, or FE. This is the one we see with long bone trauma. How is this different from a regular DVT or PE?
That's a really high-yield clinical distinction to make. A fat embolism is when fat globules, released from the bone marrow after a big fracture, think femur or pelvis, get into the bloodstream and travel.
Where do they go?
Usually the lungs, the brain, or the skin. Our notes really emphasize the association here. FE is linked to DVT and PE, but the key clinical clue is where it comes from. Lower extremity trauma is the #1 risk factor.
So if you have a patient with a fresh femur fracture, your alarm bells for FE should be ringing.
Exactly. You should be looking for the classic triad of FE symptoms.
Which is?
#1, respiratory symptoms, so shortness of breath, hypoxia. #2, neurological symptoms like confusion, restlessness, which can be tricky to differentiate from just, post-op anxiety.
Right.
And #3, and this is the big differentiator from a standard blood clot, is a petechial rash. Tiny little red spots, usually on the chest, neck, and in the armpits. That rash is a hallmark sign.
Okay, so let's run a classic priority scenario for the exam. You have a patient post-op for something minor, like a fractured finger, and they suddenly get restless and confused. What is the first action?
The first non-negotiable action is to assess vital signs, specifically OCO saturation and respiratory rate.
Before you even think about psychological distress.
Absolutely. Restlessness, confusion, anxiety. Those are classic signs of hypoxia. They're not getting enough oxygen. The test question is designed to tempt you to give a sedative or call psych, but you have to rule out the physiological problem first.
Airway, breathing, circulation, always.
Always. Oxygenation and perfusion are always the top priority.
Let's shift from acute trauma to chronic management. Let's start with gout. We need a really solid memory hook for the two main medications.
Okay, for gout, which is all about painful uric acid crystals, we use the C versus A mnemonic to manage the two main phases.
Okay.
So if the patient is having an acute flare, a crisis, the drug you give is colchicine.
C for crisis is colchicine.
Exactly. It's a powerful anti-inflammatory.
Yeah.
But a word of caution, it often has some pretty severe side effects like diarrhea.
And what about the long-term preventative approach?
So if the medication is for all the time chronic management, you give allopurinol.
A for all the time is allopurinol.
Right. Allopurinol works by stopping the body from making so much uric acid, which prevents future attacks. So C for crisis, A for all the time. That's a high-yield distinction for your test.
That's a fantastic way to remember it. Now, let's talk rheumatoid arthritis, RA. It's an autoimmune condition. The sources list prednisone and naproxen. What are the key nursing implications for that combo?
The fact that RA is autoimmune is critical because the treatment is often about suppressing the immune system. Prednisone is a potent corticosteroid used for exactly that, to suppress the immune response.
Which immediately tells you the patient is immunocompromised.
Right, so you have to be meticulous about monitoring for any sign of infection because their ability to fight things off is seriously impaired.
And naproxen, that's just a standard NSAID.
It is a non-steroidal anti-inflammatory drug. It's used for long-term symptom management. The crucial safety note for naproxen, though, is that the primary and most dangerous side effect is gastrointestinal bleeding.
From stomach ulcers.
Yeah. NSAIDs inhibit protective prostaglandins in the stomach lining. So the nurse has to watch closely for signs of a GI bleed, specifically dark or black stools, which we call melena. And you need to teach the patient to always take this medication with food to minimize that irritation.
Got it. A quick tip for the osteoporosis medication, alendronate. It seems simple, but I hear improper administration can cause some serious problems.
It can. Alendronate is a bisphosphonate, great for increasing bone density. But if it sits in the esophagus, it can cause severe irritation, even ulceration.
So patient education is key.
Vital. They must take it with a full glass of water, not just a sip, and they have to remain upright for at least 30 minutes after they swallow it. This ensures it gets down into the stomach quickly and doesn't damage the esophagus.
Okay, finally in this section, let's reinforce the absolute rule for musculoskeletal infections like MRSA with osteomyelitis. There's a mandatory two-step process before you even think about starting therapy.
Yes, and this sequence applies to pretty much any serious infection. Priority action number 1. Put the patient in isolation first. If you even suspect MRSA, they go on specific contact precautions immediately to prevent it from spreading.
And then?
Then, priority action number 2. Before you give any antibiotic, you must get a culture and sensitivity first.
So you know what you're treating.
So you know exactly what pathogen you're fighting and what drugs it's sensitive to. It optimizes treatment and, it's our best defense against antibiotic resistance.
All right, let's pivot sharply into the endocrine system. These are the body's master regulators. Small imbalances here can lead to massive acute disaster.
They really can.
We need solid memory hooks, especially for managing calcium. Hyper and hypo states are treated with opposing drugs.
This is a classic high-stakes distinction. Calcium levels are so tightly regulated, and we have to keep these medications straight.
So here's where it gets really crucial for memory. How do we keep our hyper and hypocalcemia drugs straight, especially when they sound a little similar?
Okay, for hypercalcemia, when calcium levels are dangerously high, you give calcitonin.
Calcitonin.
And the mnemonic is simple. Calcitonin is the drug that helps tone down the calcium level.
Tone it down. I like that.
It works by inhibiting the cells that break down bone and release calcium into the blood. So calcitonin tones it down.
And conversely, when calcium is dangerously low for hypocalcemia.
That's an acute, potentially life-threatening emergency. You give calcium gluconate the fourth.
Calcium gluconate.
Yeah. Think of it as giving the glue you need to bring the calcium levels UP fast in a crisis. Clinically, you're looking for signs of neuromuscular excitability.
What Chvostek's sign?
Exactly, Chvostek's sign, where you tap the cheek and the facial muscles spasm. That's a classic sign.
This comes up a lot after specific surgeries, right? Like if a patient is post-thyroidectomy and they start having muscle twitching.
That is an immediate red flag for hypocalcemia.
Why that surgery in particular?
Because the tiny parathyroid glands, which regulate calcium, are right next to the thyroid. They can get traumatized or even accidentally removed during the surgery. That muscle twitching is tetany, and it demands immediate intervention. Give calcium gluconate the fifth to stabilize them before they have a seizure or laryngospasm.
What about the chronic side of things? For hyperparathyroidism,
If a patient has chronic hypercalcemia from hyperparathyroidism, they're often on a medication called cinacalcet. It basically tricks the parathyroid gland into thinking calcium levels are higher than they are, so it releases less hormone, and that brings the serum calcium down.
okay, let's move to the thyroid spectrum. The fast state, Graves' disease, versus the slow state, hypothyroidism. You have to recognize these instantly.
Right, the complete opposites. Hyperthyroidism or Graves' disease is like the body's metabolism is floored. The clinical picture is intense. You have increased BP, increased heart rate, weight loss, heat intolerance.
And the patient themselves.
They're highly anxious, jittery, agitated. Their cardiovascular system is just overloaded. So we treat the most dangerous symptoms first, the tachycardia and hypertension, with a beta blocker, like propranolol. It blocks those intense adrenaline-like effects.
But anytime you give a drug that affects heart rate or blood pressure, you need a baseline.
You must check the BP and HR first before giving propranolol. If they're already hypotensive for some reason, giving a beta blocker could cause a complete circulatory collapse. You have to check first.
And the high-stakes complication of this is thyroid storm.
Right. Thyroid storm is a life-threatening version of hyperthyroidism. The presentation is extreme. Super high fever, extreme agitation, severe hypertension, and cardiac dysrhythmias. It's an all-hands-on-deck emergency.
Then on the opposite side, we have hypothyroidism, the slow state. The treatment is replacement therapy with levothyroxine.
Yes, the standard drug is levothyroxine. But the patient education here is what makes or breaks the treatment. It absolutely has to be taken every day on an empty stomach at the same time.
Usually first thing in the morning.
Typically 30 to 60 minutes before breakfast. Food, especially things with calcium or iron, just kills its absorption. And critically, patients should not change brands without talking to their provider,
Why not?
because different manufacturers might have slight variations in bioavailability, and even a tiny change can throw their levels way off. It has a very narrow therapeutic index.
And the life-threatening extreme of this low state is myxedema coma.
Myxedema coma is a critical emergency. It's the total opposite of thyroid storm. Everything is severely depressed, their level of consciousness, they're hypotensive, bradycardic, hypoglycemic. It requires aggressive IV thyroid hormone replacement and supportive care like warming.
Okay, if we connect this to the bigger picture, we have to talk about the fluid balance extremes governed by ADH, antidiuretic hormone.
Yes. Understanding the relationship between ADH and sodium is critical for telling DI and SIADH apart.
Let's start with diabetes insipidus, or DI. This is the one where they're peeing out the roof.
That's a good way to put it. DI is when you don't have enough ADH. And ADH's job is to tell the kidneys to hold on to water. Without it, you get massive polyuria, huge volumes of really dilute urine,
So the primary concern is dehydration.
severe dehydration, and consequently hypernatremia, which is dangerously high sodium. Because you're losing all this free water, the sodium left behind in your blood gets super concentrated.
And SIDH syndrome of inappropriate ADH is the exact opposite.
Exactly. SIADH means you have too much ADH. The body is holding on to way too much water, leading to fluid overload.
And what does that do to the sodium?
It dilutes it. This excess fluid leads to dilutional hyponatremia, dangerously low sodium levels. And the symptoms are all related to that low sodium, confusion, lethargy, even seizures. The treatment is fluid restriction and diuretics.
Okay, finally for this section, a rapid recall on diabetes mellitus. We need that classic presentation mnemonic.
The three classic P's of uncontrolled diabetes: polydipsia, which is excessive thirst;
Right.
polyuria, excessive urination as the kidneys try to dump all that extra sugar; and polyphagia, which is excessive hunger because the cells are starving for glucose, even though it's all stuck in the blood.
Thirst, urination, hunger. Got it. And a quick note on diet. Recognizing high sodium foods is key.
Oh, absolutely. For a low-sodium diet, you have to avoid processed and canned foods. So things like canned tomato soup, fried chicken, grilled cheese, enchiladas, those are all loaded with sodium.
So what's the go-to?
The advice is always the same. Choose green, leafy vegetables, high in vitamins and fiber, naturally low in sodium.
Let's shift gears to the heart and circulation. In acute cardiac care, the order of interventions is sacred, especially in an acute myocardial infarction, an MI.
Absolutely. Recognizing the presentation is step one. The patient is usually restless, their OSAT is dropping, they have that crushing chest pain, and they're often diaphoretic, just sweating buckets. It's a massive stress response.
The clock is ticking. What is the nursing priority stack? Why is the sequence so important?
We use the sequence to minimize tissue death. So, number one, give supplemental oxygen immediately. That is the absolute priority. The heart muscle is dying from lack of blood flow.
So you're trying to maximize what little oxygen is getting through.
Exactly. Maximize the oxygen carried by the remaining blood supply to limit the size of the heart attack. Number 2, establish baseline vitals and get IV access. We need to know their BP and heart rate before we give any drugs. And number 3, monitor their heart rhythm continuously. The biggest risk in those first few hours is a fatal dysrhythmia, like VFib.
And what are the crucial do-nots in this situation?
Do not sedate the patient. You need to monitor their mental status. A change could mean their brain isn't getting enough oxygen. And while blood sugar is important, don't prioritize checking it over getting oxygen on them and stabilizing their heart.
Next, heart failure. We have to be able to instantly tell the difference between left-sided and right-sided failure.
It all comes down to where the blood backs up. The left side of the heart pumps blood out to the body. So if it fails, blood backs up into the lungs.
Left for lungs.
Left for lungs. The result is pulmonary congestion, pulmonary edema. You'll hear crackles, they'll have a cough, they can't breathe when they lie flat.
And right-sided failure is the opposite.
Exactly. The right side of the heart gets blood from the systemic circulation. If it fails, blood backs up systemically into the body.
So you see it in the periphery.
You do. The signs are jugular venous distension, JVD, edema in the legs, fluid in the abdomen, and you can get an enlarged spleen and liver. The patient looks bloated and swollen all over.
A quick but critical check for major vascular surgery. After an abdominal aortic aneurysm or AAA repair, what is the one assessment you must prioritize?
After a massive repair of the aorta, the absolute highest priority is making sure blood is still getting to the lower extremities. So the key assessment is checking pedal pulses frequently.
The pulses in the feet?
The dorsalis pedis and posterior tibial. Any decrease or absence of those pulses, or if the legs get cold, suggests the graft's clotted off. That is an immediate surgical emergency to save the limb.
Let's talk anticoagulation. The therapeutic overlap between heparin and warfarin. If you start warfarin for a PE, why can't you just stop the heparin right away?
It's all about how fast they work. Heparin is immediate. It gives you rapid protection. But warfarin, which is a pill, is slow. It can take 3 to 5 days to reach a therapeutic level.
So you need a bridge.
You need a bridge. The essential action is to start the warfarin, or Coumadin, and continue the heparin until the warfarin becomes therapeutic. You need that overlap coverage to prevent another clot from forming.
And the monitoring labs are different for each?
They are. For heparin, you monitor the partial thromboplastin time, or PTT. A therapeutic PTT is usually in the triple digits, greater than 60, or about 1.5 to 2.5 times their baseline. Their PTT is 35, that is not therapeutic. They're still at risk of clotting, and you need to call the provider to increase the dose.
And for warfarin, we use the INR.
Correct. Warfarin is monitored by the INR, the International Normalized Ratio, and the therapeutic goal is usually an INR between 2.0 and 3.0.
What's the critical action if you see signs of severe bleeding while a patient is on heparin? Let's say bleeding from the ears.
That's a classic priority question. The action is immediate and non-negotiable. Stop the heparin infusion first.
Before you can call anyone.
Before you do anything else. Stop the drug that's causing the problem. Heparin has a short half-life, but you have to stop the input. Then you call the provider immediately to get the reversal agent and figure out the next steps. And this raises an important question. In acute care, which lab values demand an immediate life-saving intervention? We have to know these goals.
Okay, let's focus on the critical alarms, the ones that need an urgent call right now.
There are 3 numbers that should trigger an immediate alarm for you. 1, potassium less than 3. Potassium is critical for cardiac stability. When it's that low, the risk of a fatal dysrhythmia, specifically VFib, is incredibly high. Even 3.1 is borderline, but less than 3 is an emergency.
What's the second critical number?
2, a PTT over 100 seconds in a patient on heparin. This means they are way over anticoagulated and are at severe risk for a spontaneous bleed, like in the brain or the GI tract. You have to stop that infusion.
And the third?
3, while maybe not as immediately life-threatening, is a significantly elevated WBC count. It points to a serious systemic infection or sepsis that needs an immediate workup. And just for context, remember normal sodium is around 135 and normal BUN is around 15. It helps you see how far off the other values are.
And a final reminder, if a telemetry monitor goes off.
You always assess the patient and check their pulse first. Before you look at the monitor, before you fix the leads. The alarm could be a false alarm because they scratched themselves, or it could be cardiac arrest. Your hands and your eyes on the patient are always your first tool.
Okay, moving to acute respiratory failure and chest trauma. We need to distinguish between two immediate life threats: tension pneumothorax and flail chest.
A tension pneumothorax is, well, it's maybe the most rapidly fatal complication we'll talk about. Air gets into the pleural space but can't get out.
Like a one-way valve.
Exactly. It builds pressure, collapses the lung, and then it starts pushing the heart and the trachea over, which cuts off blood return to the heart. It is very quickly fatal if you don't treat it.
What are the signs that just scream tension pneumo?
Massive respiratory distress, chest pain, shortness of breath, severe hypoxia. On exam, you'll have absent breath sounds on one side, but the absolute classic red flag signs are deviation of the trachea away from the affected side, distended neck veins, and hemodynamic instability, so their blood pressure tanks. That tracheal shift is a very grave, very late sign.
And the immediate treatment.
You have to relieve that pressure immediately, first with a needle decompression, then by placing a chest tube to drain the air.
How does that compare to flail chest?
Flail chest is a mechanical injury.
Mm.
It's caused by multiple rib fractures in a row, which creates a segment of the chest wall that's just detached from the rest of the rib cage.
So it moves independently.
It does. And the cardinal sign you have to recognize is paradoxical chest movement. When the patient breathes in, that broken segment gets sucked inward. When they breathe out, it bulges outward. It severely messes with their ability to get a good breath.
Let's apply this. Trauma patient, multiple rib fractures, chest pain, SOB, diminished breath sounds, tachycardic, hypotensive, SPO of 86%. What's the priority?
With that SPO of 86% and the signs of shock, the patient is hypoxic and unstable. The priority action is to initiate oxygen therapy immediately. Secure the airway and maximize oxygen delivery before you do anything else.
Let's dedicate some time to chest tube management. This is a huge area for exams and for clinical risk.
It is. The purpose of a chest tube is to restore that negative pressure in the pleural space to help the lung re-expand. Patient assessment is continuous. You're looking for difficulty breathing, monitoring their OZAD, listening to breath sounds, and encouraging CTDB cough, turn, deep breath to promote lung expansion.
And managing the drainage system itself requires meticulous checks. Let's talk about the water seal and suction chambers.
Okay, you must keep the drainage system lower than the patient's chest to let gravity do its work. Then you look at the water seal chamber. You should see tidling. That's the expected rise and fall of the water level as they breathe. If it's tidling, the system is working.
And what about bubbling? That seems to confuse a lot of people.
You have to know the difference between normal and abnormal bubbling. In the water seal chamber, you should only see bubbling intermittently, like when they cough or change position. Continuous excessive bubbling suggests a persistent air leak, and that's abnormal. You have to troubleshoot that.
Let's drill down on the immediate warning signs that mean you need to call the provider right now.
4 absolute red flags. 1, drainage greater than 70 milliliters per hour. That suggests active bleeding.
Okay.
2, you see visible eyelets on the chest tube, meaning the tube is pulled out of the chest wall. 3, drainage in the tube stops abruptly in the first 24 hours. That suggests a clot. And 4, the tube gets completely dislodged from the chest.
If that last one happens, the tube is pulled clean out. What is the immediate non-negotiable nursing action?
It's a life-saving sequence. You cover the wound immediately with sterile gauze, followed by a petroleum dressing to create an occlusive seal. But, and this is key, you only tape it on 3 sides.
Why 3 sides?
It creates a one-way valve, so air trapped inside the chest can get out when they exhale, but air from the outside can't get in. It prevents a tension pneumothorax from forming. And you have to keep those supplies at the bedside at all times.
Let's quickly differentiate that from a mediastinal tube, one that's in the pericardial space after open heart surgery.
The risk there is different. It's cardiac tamponade, where blood builds up around the heart and squeezes it. Bloody drainage is expected after surgery, but the critical threshold is different. Drainage should not exceed 100 milliliters per hour, and you're checking that hourly. A sudden drop in drainage is also an alarm, because it could mean a clot is forming and causing tamponade.
Finally, COPD. A chronic emphysema patient is on O-Euro at 5 liters. What respiration rate should trigger an alarm?
A rate of 8 breaths per minute is a critical alarm. That's dangerously low. It means they're hypoventilating.
Because you've knocked out their hypoxic drive.
Exactly. Many chronic COPD patients rely on low oxygen levels to stimulate their breathing. Giving too much OROS can actually make them stop breathing.
And what are the typical signs of a COPD exacerbation that we do expect to see?
You expect to see the body struggling. The tripod position, where they lean forward to breathe, breathing really fast, like 40 times a minute. And wheezing from bronchoconstriction. Things you would not see are tracheal deviation, That's a tension pneumo or a normal pH, which wouldn't reflect the respiratory acidosis of a severe exacerbation.
Okay, we are diving into the nervous system now. Intracranial pressure, or ICP, management is first. What's the normal range?
The skull is a fixed box, so pressure is everything. The normal range for ICP is very narrow, 10 to 15 millimilli EHG. Anything above that starts to compromise blood flow to the brain.
So what's the priority if ICP elevates, say, to a dangerous level like 33 during a routine activity like bathing?
The priority is absolute. Stop the activity immediately. Anything that causes straining, coughing, or even big postural changes can cause a spike in ICP. When it's high, you have to minimize all stimulation.
Next, autonomic dysreflexia, or AD. This is a high-risk complication in patients with upper spinal cord injuries.
Yes, T6 or above. AD is a massive, uncontrolled sympathetic response to some kind of noxious stimulus below the level of the injury.
And the immediate danger is?
Severe uncontrolled hypertension. Their blood pressure shoots up, and they're at risk of a stroke or seizure.
Since the patient can't feel the trigger, the nursing actions are all about investigation. What's the plan?
It's a sequence. 1, check their BP frequently and get it down. But 2, you start systematically searching for the cause. The most common trigger is the distended bladder. So you check their Foley catheter to see if it's kinked or clogged.
And if that's not it?
You look at their abdomen for bowel distension. You assess their skin for anything pressing on them, wrinkles in the sheet, tight clothing, anything. The nurse has to be their senses below the level of injury.
Finally, a neurological drug caution for Imitrex or sumatriptan.
Right. Imitrex is for migraines, but it works through powerful vasoconstriction. So you must question the medication if the patient has uncontrolled hypertension or coronary artery disease. Giving a powerful vasoconstrictor to someone who's already hypertensive can cause a hypertensive crisis or an MI.
And a quick anatomy recall.
The hypothalamus is the primary regulator of body temperature.
Okay, last section. We have to reinforce the core clinical principles that cross every single system.
Yes, these are the foundations.
We've said it before, but when a telemetry monitor alarms,
You always assess the patient and check their pulse first before you ever touch the monitor. It could be artifact or it could be cardiac arrest. The patient is always the priority.
and the culture rule for infections.
Always get a culture and sensitivity first before starting antibiotics. This ensures you're using the right drug for the right bug, which is essential for effective treatment and for fighting antibiotic resistance.
Let's quickly review blood transfusion reactions. What are the key signs of an allergic or anaphylactic reaction?
You're watching for 3 things, usually in the first 15 minutes. Itching and a rash, that's an allergic reaction. But the critical sign that signals anaphylaxis is a rapid drop in blood pressure. That's a medical emergency. You stop the infusion immediately and get the rescue meds.
Finally, let's not forget the psychosocial and communication aspect.
It's so important. Always perform psychosocial assessments alongside your physical ones.
Yeah?
And remember to ask those basic questions to characterize pain. What makes it worse? What makes it better? Is it constant or does it come and go? This is the foundation of good symptom management.
We just completed a crucial, high-speed deep dive. We didn't just list facts. We really explored the why behind the priority stacking, from getting oxygen on an MI patient first to the mechanics of chest tubes.
Exactly. And we armed you with mnemonics like C for crisis colchicine and A for all the time albupurinol.
The speed of retention really relies on understanding those connections and being able to differentiate between these conditions.
It does. Remember the opposition between thyroid storm and mixed edema coma, or DI versus SIADH. And most importantly, practice that hierarchy in your head. Always assess first, always culture first, and know your therapeutic ranges so you can recognize a crisis before it happens.
And in that moment of clinical stress, whether it's in the exam room or at the bedside, recognizing the smallest metric as the largest alarm is what saves a life.
Absolutely. The jump from knowing the information to being a competent practitioner is all about recognizing those alarms instantly. You've memorized the ranges, but now you need to use that knowledge as an actionable trigger. So as you reflect on this, consider this final provocative thought. You know the limits now. What single abnormal reading, be it potassium less than 3 or a PTT over 100, will be your trigger to call for immediate help. Focus on that moment of decisive, informed action, and you will ace that test.
That's a powerful note to end on. Study smart, prioritize, and we'll see you on the next deep dive.